Good evening, everyone. Thank you so much for joining us today. My name is Dr. Dana Lewis, and I'm a third-year fellow in the F.J. Montz Gynecologic Oncology Fellowship Program here at Johns Hopkins School of Medicine. I'll be serving as your host and moderator for today's discussion, HPV Knowledge and Prevention. We're very glad you could be with us tonight. January is HPV Awareness Month, a time to focus on education, prevention, and the latest advances in care related to one of the most common viral infections worldwide. HPV affects millions of people, yet misconceptions and unanswered questions still remain, particularly when it comes to screening, prevention, and long-term health outcomes. Today's conversation is designed to provide clear, evidence-based information about HPV and its role in cervical and gynecologic cancers. We'll discuss why prevention and early detection matter, how cervical cancer and precancerous conditions are diagnosed and treated, and what emerging research may mean for the future of care, especially efforts aimed at intercepting HPV-related cancers before they develop. I'm honored to be joined by two leading experts from Johns Hopkins Medicine. Dr. Kimberly Levinson is an associate professor in the Department of Gynecology and Obstetrics at Johns Hopkins and director of Gynecologic Oncology at Greater Baltimore Medical Center. Her clinical expertise includes minimally invasive and robotic surgery, as well as the treatment of cervical cancer and dysplasia. Her research focuses on cervical cancer prevention, healthcare disparities in gynecologic oncology, and surgical innovation, and she currently serves as a principal investigator in the SPORE in cervical cancer. Dr. Cornelia Trimble is a professor in the Department of Gynecology and Obstetrics, Oncology, and Pathology at Johns Hopkins. She is the director of the Johns Hopkins Center for Cervical Dysplasia at Johns Hopkins. Her work has focused on developing non-surgical treatment strategies for HPV precancers, such as therapeutic HPV vaccines, and using topical treatments for high-grade HPV lesions. Today's program will feature a discussion with both Dr. Levinson and Trimble, followed by time for audience questions. If you're watching live, we encourage you to submit your questions using the chat feature throughout the program, and we'll do our best to address as many as we can at the end. This program is presented by the Kelly Gynecologic Oncology Service, the Johns Hopkins School of Medicine, and Hopkins at Home. We're grateful for their partnership and shared commitment to education, prevention, and advancing patient-centered care. These are the related disclosures for both Dr. Levinson and Dr. Trimble. With that, let's begin our conversation.
All righty. Thanks so much, Dr. Lewis. We're really looking forward to this conversation today and hope that you find it helpful. So I thought I'd begin by walking through some questions, common questions that my new patients bring with them, especially at their first visits. So the first is, they think I have HPV, I'm a bad person. Second, I'm gonna get HPV cancer and die. The third is, I have HPV, there's no point in getting the vaccine now. That's not true. And some of them even tell me I have HPV. I'm never gonna, again, bad idea. So the first thing I want you to know and remember is that anyone who has had sex has basically been exposed to HPV. The reason everybody has it is because you can't tell you about it. There's no signs, no symptoms, it doesn't get into the system, you don't feel sick. It's not an ulcer or a drip or an itch or anything. And in fact, it's so bland and there's so much else going on down there, if you will, that when your cervix immune system first encounters the HPV, it's going, is that something I have to do something about right away? Or can I put it maybe 4 or 5 on my to-do list? And quite frankly, that's where it is. That's where it ends up. All of which is to say that the immune responses that we make to the HPV are not very strong. They're kind of limp. So Dr. Levinson is going to take it away and explain to you what HPV is all about.
Thanks so much, Dr. Trimble. I think that's an excellent way to explain how common HPV is and why there are so few symptoms from this virus. So in fact, infection with HPV can lead to various diseases, and these can include warts, including genital warts. And warts are actually caused by the low-risk types of HPV. And we're going to talk a little bit about low-risk types and high-risk types and help you understand what all those mean. Those infections or those specific HPV types are usually type 6 and 11, which cause the genital warts, primarily in the area of the vulva and the perianal tissues. And infections with these types does not lead to cancer, and that's really important. In addition to genital warts, HPV can also cause cancers, as we know. And so the cancers are actually caused by infection with the high-risk HPV types, and those primarily do affect the anogenital tract as well as the oropharynx. And then very rarely, HPV can also lead to some rare respiratory lesions and cutaneous lesions. So today we're primarily going to focus on the high-risk types that cause cancer. And worldwide, the human papillomavirus causes approximately 730,000 cases of cancer per year. And that's about 4% of cancers overall, actually. And so while there's great variation in the distribution of these cancers, with the majority of them being, in Africa, HPV attributable cancers there are up to 38%, whereas in the US, they're only about 2% of cancers. So HPV mostly affects the cancers of the lower genital tract, including the cervix, vulva, vagina, anus, and penis. And then also, as I mentioned, oropharyngeal cancers, which can be HPV related. And while HPV-related oropharyngeal cancers account for about 30% of those cancers, cervical cancers are almost 100% caused by HPV. And in the US, there are just over 13,000 cases of cervical cancer each year, and this disease causes approximately 4,300 deaths per year. So in thinking about cervical cancer and HPV, it's important to understand that the virus actually has many different genotypes, actually over 200, and not all of them cause cancer. In fact, there's only about 19 types that directly are related to cancer. And so what we have come to understand is that 2 types in particular actually cause the majority of cervical cancers. And those 2 types are types 16 and 18. And we call those the most oncogenic, or the most likely to cause cancer. And so these types are responsible for approximately 70% of cervical cancers. And then type 33 is actually responsible for another 5%. And it's about 8 types together that are responsible for about 90% of cancers. And so various types may be more or less prevalent in different parts of the world. And so it's important to understand kind of what the different prevalence of these HPV types is, and to most importantly understand that types 16 and 18 are the 2 that we are the most concerned about.
This is all very helpful information. Despite decades of research and effective screening tools, HPV-related cancers remain a significant public health issue. Doctors Trimble and Levinson, can you help us to understand what are the best ways to prevent HPV and cervical cancer?
Yeah, thank you, Dr. Lewis. This is a critical part of the conversation that we want to cover today. So there's essentially 2 different approaches to prevention of cervical cancer. The first is primary prevention, which specifically means the prevention of disease before it occurs. So in this setting, we're talking about preventing ever getting HPV. And primary prevention for HPV is really through the preventative vaccine, the Gardasil vaccine. Secondary prevention, on the other hand, refers to early detection of a disease. And in this setting, we're talking about cervical cancer screening, or what many refer to as pap smear screening. And so Dr. Trimble is going to talk a little bit more about secondary prevention and cervical cancer screening for us.
I wanted to give you sort of a broad overview, because over the course of the next 45 minutes, we're going to be giving an awful lot of information. So the overview of the cervix, what to expect. A normal cervix, we screen for the presence of HPV, basically. And we can do that with a pap smear or with HPV testing. And you can also, at that point, get the preventive HPV vaccine. Okay, now, in the case of detectable HPV, these are very common pap smear diagnoses. The most common clinical setting is to have a normal pap smear and detectable HPV. Nothing to do, it drives my patients crazy. All 4 of these diagnoses are basically clinically, they behave the same. And if that's all you have, we don't treat you because these in and of themselves, the HPV infections, are not considered to be precancerous. And we think of them as an HPV infection. A lot of them go away. But if you have detectable HPV, what we do is a procedure called a colposcopy. And that's just to get a really closer look at your cervix. And the main point of that is to make sure you don't have a sneaky little high-grade lesion up there. The idea is to find precancerous, CIN2-3. If you do have that, then we treat you. At the moment, we treat you with a small surgery. It's not small for you, but it's a tiny surgery. And in this day and age, we should not be able to have HPV cancer on the continuum. Not all HPV precancers turn into cancer. Some of them do go away, and that's the focus of Dr. Levinson and my work, which we'll tell you about. If it does turn into cancer, we think that the time frame is on the order of maybe 10 to 15 years. So this is the point at which we want to intervene and prevent cancer. And I just want to say this, a high-risk HPV type is not the same thing as a high-grade lesion. They just sound the same. Neither of them sounds very good. The high-grade lesions is the precancer, CIN2-3. The high-risk HPV type is what Dr. Levinson just told you about, which is the HPVs that are most commonly found in cervical and genital tract lesions. Okay, Dr. Levinson's now going to tell you what I just said.
So thank you, Dr. Trimble. Yeah. So one of the things that I think is important is that I think that people use the term pap smear many times to mean different things. And so many times the people use the word pap smear, the language of pap smear, to mean that they're getting cervical screening, but there can be a lot of different things that people are actually including in that. So really what a pap smear is a brush to sample the cells of the cervix. And the goal of that is to, as Dr. Trimble was saying, to try to identify if there are changes to the cells around the cervical area. So to identify a precancer or cervical dysplasia, or what we call CIN2-3. A pap smear, what people usually talk about as a pap smear is what we're talking about with what we call cytology, looking at cells under the microscope, okay? But sometimes when we do a screening test, we're not only looking at cytology, we also will do an actual test for HPV. And so when we do both of those, that is actually called a co-test, a pap smear and an HPV test. So sometimes people will get a pap smear alone, sometimes people will get an HPV test alone, and sometimes people will get what's called a co-test, where both of those things are tested. So the goal of cervical cancer screening is, of course, to accurately identify patients that are having precancer of the cervix, as Dr. Trimble said, CIN2-3. So specifically, we want to identify those high-grade cells. For cervical cancer, as Dr. Trimble said, there's this long process for cervical cancer to develop. And so that starts with the HPV infection. If the virus stays around in the cervix without clearing, then those cellular changes begin to occur. So there's 3 parts to cervical cancer screening. First is the test. So the testing is the pap smear or the HPV testing or the co-test, like we said. The next thing is the triage of the test. And so if you have a positive pap smear or a positive HPV test or a positive co-test, then we want to try to define who is truly at risk for precancer. And then the final part is actually the treatment, once we've identified who actually has those precancerous lesions. So Dr. Trimble is going to describe a little bit about what happens when somebody has an abnormal pap smear and an abnormal cervical screening.
So if your pap smear screening is abnormal, it doesn't mean that you have cancer. It may mean that your HPV was detected. The cytology, the pap smear wasn't entirely normal. And so neither one of these, I want to emphasize, mean that you have cancer or even a precancer. It just means we need to take a closer look. And that's a procedure called a colposcopy. And you should get off the internet right now and stop looking up colposcopy because you'll go down some rabbit holes. What we do is we apply a very dilute vinegar solution under your cervix and then look really carefully with this scope called a colposcope. And what the vinegar does is it highlights where abnormal cells are. So we're looking for really specific patterns. We're going to tell you what we're seeing, what we're thinking, and if we're going to get a biopsy, we work with you. I count down from 3. 3, 2, 1. Cough. And at the time they cough, it's when I get the biopsy, which is about the size of a sesame seed. So the next step after that is to look at the pathology, the tissue itself, to see what you've got going on. And that's the gold standard. Okay, so a colposcope is actually, it's not as scary as it sounds. It's like a binoculars. It's a microscope that's used to look at the cervix cells. And acetic acid is the vinegar I was telling you about. And the abnormal cells dehydrate faster than normal cells. And when they do that, they turn white. So we're looking for patterns of white, specific patterns of white. And again, we'll tell you what we're seeing and what we're thinking. If there's an area that suggests an abnormality or something that could be causing your abnormal pap smear, in general, we'll biopsy it. And we will also most likely get a sample of cells from your endocervix, your birth canal inside your cervix, because HPV can go there too, and we can't see it. Okay, so we're just being really, really careful. And what the results mean. Low-grade lesions, CIN1, represent HPV infection. Okay, and so we don't have a treatment for HPV infection yet. Investigators are working really hard on doing that. Turns out it's more difficult than we thought. The high grade is a little bit easier because we have ways of screening exactly for that. And as I said before, the reason we want to find this setting is because that's cancers grow out from untreated high-grade lesions. And it takes a really, really long time if it's going to do that. And our research has to do with developing non-surgical treatments for these precancers. Okay, how do we treat patients, Dr. Levinson?
Yeah, so the treatment of a CIN2 lesion or a high-grade lesion or precancerous lesion is to remove those abnormal cells. And so this picture here shows both removal of kind of that outside area of the cervix where Dr. Trimble was describing we can take a biopsy from, or even that little inside part. And so when we remove this area of the cervix, which is essentially a larger biopsy, we want to encompass both of those areas because that's the area that HPV likes the most, so to speak. So that's the area where the HPV causes cellular changes. So the goal is to remove those abnormal cells before they become a cancer. And there's 2 different ways that we can do that. We can either do that with what's called electrocautery. So that procedure is called a loop electrosurgical excision procedure, which uses a little loop to kind of excise that area. Or we can do what's called a cold conization. And a cold conization just uses a knife to do the same thing. And there's different reasons why we may do one or the other. For example, if there's a lesion higher up in the cervical canal, we may often do a cold conization to try to get cleanly around that area. But both effectively will remove those abnormal precancerous cells. So one of the things that I want to highlight also is that it's important to remember that cervical cancer at its earlier stages often doesn't cause any specific symptoms. And so the main and most important thing about screening is that screening is critical because people will not have symptoms for early stage cervical cancers. And therefore, this is really the best way for us to find cancers, early cancers, or ideally precancers, to treat them before they become something bad. There are some symptoms from advanced stage cancers. Those can include bleeding. They can include leg swelling once the cancer has extended to affect the pelvic sidewall, or leg or back pain. But as I said, often those symptoms really only arise once the disease is very advanced. And so it's important to get screening because that really is the best way for us to identify early changes. So Dr. Trimble will now discuss kind of the current screening guidelines and how someone might know how often they should be screened.
So broadly, we don't screen before age 21, even if a person is sexually active, or between 21 and 29 also. So most often those lesions will clear. The other, after we use a cutoff of 30 years, HPV can persist and cause changes. And the pap smears are not 100%. That's why we get serial longitudinal pap smears. HPV testing is more sensitive, in part because it's objective, it's not subjective. Either we find it or we don't. And if your HPV is negative, then your risk of abnormality within 5 years is really, really small. And the reason we do both a pap smear and HPV testing is that it's more information, and that helps us. Technically, the guidelines tell us to stop screening at the age of 65. But, if you've had a history of a high-grade lesion that's been treated or some other clinical settings, if you're immune suppressed, we just go ahead and keep screening. So we don't cut you off. But please keep in mind that the most common clinical setting is to have a normal pap smear and detectable HPV. It's not cancer.
Excellent. So we're going to move on to talk a little bit more about primary prevention. So preventing HPV before it occurs is what that means. And the best way for us to do that, as I had previously mentioned, is with the preventive vaccine. And so what that means is that we want to administer, ideally, the vaccine. The Gardasil vaccine is the vaccine that's currently approved. We want to administer that as early as possible, and ideally before there's any sexual exposure to HPV. So the very first FDA approval for a preventive HPV vaccine was actually back in 2006. And those initial vaccinations that were approved really only covered the two highest risk types, so 16 and 18. And now we have Gardasil 9 in the United States, and that's the vaccination that we currently use for prevention. And that's the one that you might have seen on television a lot. It's often frequently advertised. And it's called Gardasil 9 because it actually covers against 9 HPV types. And so if you remember back to the slide that I presented in the very beginning, that's going to cover up to about 90% of cervical cancers. So that coverage is really quite good, and covers the 7 most common high-risk HPV types, as well as those 2 types, 6 and 11, that cause genital warts. And so this is a really important vaccine for us. So who should be vaccinated with Gardasil 9 and when? So here you see the current vaccination guidelines for HPV preventive vaccine. And the bottom line is really the earlier the better, and the vaccine works best if given prior to exposure to HPV. The good news is that this intervention is very low risk, and we have excellent data looking at this vaccine in terms of both safety and its effectiveness. And so we know that this vaccine works, which is excellent. The primary issue with prevention with the Gardasil vaccine is that coverage still remains somewhat limited and access to vaccination remains somewhat limited. And so we still have many, many individuals who have not been vaccinated or have not been able to get the vaccine. And in addition to that, many patients have been exposed prior to being able to be vaccinated. So Dr. Trimble is going to tell us a little bit more about the preventive HPV vaccine in patients who are older, who are not children, and who have already been exposed to HPV.
So this is addresses a very common misconception, which is that HPV vaccination after you have had a detectable HPV is not worth anything, but that's not the case. It turns out that if you have even seen immune response, remember what we talked about in the very beginning, the reasons why the immune response that we make on our own to the HPV are not very strong and don't necessarily protect you against reinfection. Whereas Gardasil can really increase your immune response. And this we know because there's data calling in at the Fred Hutch in Seattle, initially 10 women who had low-level antibody immune responses to the HPV, so they had been exposed, and she was vaccinated. And guess what? Their immune responses went up between 100-fold up to 1,000-fold, even though they had already had a little response themselves. And what we think is going on is that the immune response we make is weak, not always effective. And in contrast, the Gardasil is engineered to make a humongous immune response, and that's what it does. Keep in mind that Gardasil has no treatment effect. However, I talk about this with a lot of my patients because in patients who have been treated for a high-grade lesion, with surgery or what have you, if you have Gardasil on board, it does really decrease the risk of recurrence after treatment. So what can I do that's under my control to optimize my own body's response to HPV? It turns out there's some things you can do. The first is to try to have no tobacco exposure. The reason this is important is because tobacco exposure actually triples the risk that the HPV won't go away. That's my one sentence, stop smoking, please, lecture. Gardasil, we just talked about, and we can talk about different ways to justify it. And the third thing you can do is to optimize your microbiome. So what does that mean? You have millions and millions of bacteria in your gut. It's a mutually beneficial arrangement. They break down nutrients that we can't, so we can use them. And we break down nutrients that they can't, so they can use them. Now then, everybody's microbiome is a little bit different. But when that balance between useful and not gets a little bit off, it can affect your entire body. It doesn't cause symptoms. You don't have funny poops or anything, and you don't feel bad. But what it can do is to set up a systemic level of chronic inflammation. Again, nothing we can measure. And that can make you more susceptible to disease. It can affect your response to treatments. And it can also, believe it or not, affect your mood. What can you do to optimize your gut and cervical microbiome? You can really, really decrease sweets and processed carbs in your in your diet. I had one patient who was sensitive, so sensitive, she would eat one burger cookie and get a yeast infection. At first we said, no, can't be the case. So we did the experiment. We treated a yeast infection. 2 weeks later, she ate one burger cookie, boom. So most people are not that sensitive, but I like to tell about her to illustrate the fact that what you eat actually does affect what's going on down there. The second thing you can do is common sense. You need to move things along, eat roughage, fruits, vegetables. And the third thing is exercise. And you need to do both cardio as well as weight bearing and do it regularly. And the benefits you'll see are not only physical, but it'll be good for your head. Because if you're like a lot of women, we spend so much energy taking care of everybody else and not so much taking care of us. And so if we set aside time for exercise, it's good for your head. You're setting aside time for only you.
Thank you both so much. This conversation has been so helpful in understanding HPV and the best ways to prevent cervical cancer. Can you both share with us where you think the greatest opportunities lie for improving outcomes over the next decade or so?
Okay. Yeah. Thanks, Dr. Lewis. From my standpoint, one of the most important issues for cervical cancer and for all HPV-associated cancers is that once a person acquires the HPV virus, it becomes very, very hard for us to get rid of it completely. Okay, so even if we get rid of it for a time being, it can always come back. And it can be what we call latent or undetectable, but can really recur at any point. So given that most of these cancers are virus associated, if we can get rid of the virus, we feel that we should be able to cure disease. And in many ways, viruses can be an ideal thing for what we would call immune therapies because they're something foreign to our body. So our immune system should be able to respond to them and be able to recognize them as something that shouldn't be there. In thinking about treating HPV as opposed to preventing HPV, it's important to recognize differences between a preventive vaccine and a therapeutic vaccine. So a preventive vaccine is usually constructed to make what we call an antibody response. So an antibody response is basically something that can teach the immune system to recognize the virus before it ever enters a cell. Okay, so it's a little piece of the immune system that says, hey, look out for that thing and don't let it get in. Okay. Therapeutic vaccines instead are really targeted at what we call activating cellular immunity. So this is a little bit different because this is where the immune system actually goes to attack a cell that has already been infected by the virus. So this is called a T cell response. And those two differences in a prophylactic vaccine versus a therapeutic vaccine are very important in us kind of thinking about the future and how we might target the virus once somebody's already has an established infection. So both Dr. Trimble and I are working currently in this area of research on therapeutic vaccination for HPV, and Dr. Trimble is going to talk a little bit more about this.
If you want a really simple explanation of the differences between a preventive vaccine and a therapeutic vaccine, you can go look at my TED Talk, which is called Kicking Cancer's Butt. Okay, so where are we going? This is this typical design of a therapeutic HPV vaccine trial for people who have pre-invasive disease, a high-grade lesion. So a person will have a diagnosis, will have to have a tissue diagnosis, and then typically the way our team does it is we administer 3 vaccinations, 3 doses, priming and boosting in response. And we can talk about the timing of those as well. We also noticed that one way that the immune response, even if it got to the cervix, wasn't able to do its job, was because there were immune suppressive influences going on. And so to counteract that, we also treat the patients with the topical immune stimulator called imiquimod, which is Aldera. We use it externally all the time to treat external HPV disease, like warts. We also use it to treat early basal cell carcinoma and also seborrheic keratosis. And we've definitely shown proof of concept for this approach. We've cured about 2/3 of patients who had HPV-16 disease, which, as you can see, is more than twice the rate of spontaneous regression. So what does that look like? I'm going to show you pictures because I'm a very visual person and a pathologist. So this is an image of a patient before vaccination. So here's the bad part. The bottom dotted line is the base of the lesion. And then I'm going to show you an enlarged area from right here, which is this image. And what I want you to notice is that the underlying tissue is pretty bland. It looks like nobody's home. And in contrast, after, look at the difference. Here's her residual lesion, which is not very big anymore. And maybe you can see these sort of clouds of dark things. Those are clusters of immune cells. And in fact, if you look at that a little bit more closely, we see characteristics that we would see in a lymph node, which actually raises the possibility of immune responses being generated in the tissue. The cells inside the dotted oval, those are immune cells. And the cells that are shrinking down with the fat arrows, that's what a dying cell looks like. So now we're in a position, and we're doing this, to figure out what a successful immune response actually looks like. We know so much about the biology, but we don't know how it makes, your immune system makes it go away. Well, we're doing this in collaboration with investigators in Seattle, using samples from my vaccinated patients to identify specific T cells that are associated with lesion regression. And also we're doing three-dimensional spatial analyses to characterize everything else that's going around in the lesion, around these T cells. And the idea eventually is to use the part of the T cell that's recognizing HPV and make an off-the-shelf library so that if a patient who has more advanced HPV cancer comes in, we can look at their immune system and match it with one of our T cell receptors off the shelf and say, oh, look, you're an HLA-201. We have 3 really good HLA-201 receptors. And we can, or you have HLA-DRB what? And so do you. So we have 2 good receptors that we know are functional and sufficient. And what we do is we engineer the patient's own T cells to express those receptors. And so it's truly personalized immunotherapies, and hopefully that's our future. We're also doing something that's a little crazy. We've repurposed a plant-derived anti-malarial compound called artesunate. It's been used by the Chinese for thousands of years to treat acute malaria. And the person who discovered the active compound was actually given the Nobel Prize because millions and millions of people are alive because of her work. So we know it's safe. And it turns out that when it comes in contact with the high-grade patient, it kills a lot of those high-grade cells. So our first trial, we formulated the artesunate into vaginal suppositories. They're the same formulation as what we used to treat yeast infection. And the patients treated themselves. Wow, right? So we would give the patient a box of 5 suppositories, and she would take it home and treat herself 5 nights in a row. We tested 1, 2, and 3 5-night cycles and cured 68% of the high-grade patients and we're using it now as an ointment to treat high-grade vulvar and perianal disease. So here's Dr. Levinson to tell us about her work.
Excellent. Thanks so much for sharing this really important work, Dr. Trimble. It's exciting to hear about, and I'll share a little bit about what I'm doing as well. So I am also working on some therapeutic vaccination trials, and we have some clinical trials that are currently open at Johns Hopkins. And the clinical trials that we are running are for two different therapeutic vaccinations. One of them is specifically targeting HPV-16, and the other is specifically targeting both 16 and 18. And we have three different trials, two of which are for patients with low-grade disease, so who might have persistent HPV, but no actual high-grade disease, to try and see if we can get rid of the virus. And one of the trials that we're running is in patients with high-grade dysplasia. So importantly, one of the ways that we have figured out that we can potentially improve the immune response to therapeutic vaccines is with what we call electroporation, which means that we're stimulating the muscle of the arm or the leg, depending on where we give the vaccination, in order to amplify the immune response. And we know that this increases the immune response up to 3 times. And that's really helpful in terms of getting the vaccine to where it needs to go and to making sure that the body mounts an appropriate T cell response. So we have 2 clinical trials that are currently ongoing, one in a low-grade population, which just uses a regular needle syringe, and the other in the high-grade population, so patients with pre-cancer, that does use the electroporation. And I have some of our preliminary outcomes, which are here in these pie graphs. And just for visualization, the blue represents patients who have completed the 6 months of the clinical trial. The yellow represents patients who have had a complete response, meaning we've gotten rid of their HPV and we've gotten rid of their high-grade dysplasia. So, again, more than half of them. On the left side is patients who are HIV negative, so who have complete immune competence. On the right side, we are actually having a cohort of patients who are living with HIV, and we've actually seen some excellent responses in those patients as well, who we know are at particularly high risk for HPV-related diseases. And so this is very exciting preliminary data, and we will continue to enroll in this trial. In addition, if you flip to the next slide, one of my strong interests is also high-risk populations. So I talked a little bit about inclusion of both individuals living with HIV in our therapeutic vaccination trials. But I also work with a national consortium called the AIDS Malignancy Consortium, which focuses on clinical trials which we can run nationally to try to look at larger populations. And one of the trials which we are looking to open, which I will be leading, is a trial that, again, repurposes a medication that has been used for other things. So to treat HIV, we actually use certain type of drugs called protease inhibitors. And this is a combination of lopinavir and ritonavir, which we use orally to treat HIV. And what we know is that some of the same mechanisms that HIV uses to get into the cell are some of the same mechanisms that HPV uses to get into the cell. And so there have been some preliminary studies that have looked at this to say, can we repurpose this medication to also fight against HPV? And in preliminary studies that were done in HIV negative patients, so patients without HIV, there was quite a substantial response to this drug utilized as a vaginal suppository. And so we are looking to now do this in individuals living with HIV who have high-grade cervical dysplasia, and we're hoping to be able to open that clinical trial within the next year nationally.
Those are very impressive results.
It's exciting. I think, all of this is such exciting research. And I know this is, both Dr. Trimble and I feel so passionate about this, what is on the precipice of coming.
Yeah, I like to say, Dr. Levinson and I, our goal is to put ourselves out of 50s. Okay,
Absolutely.
well, Raf, thank you so much for your time and attention this evening. If this research is inspiring to you, and you want to know more about supporting this, we'll give you instructions on a donation page. And in the meantime, sorry. In the meantime, how to reach us. I see patients at Great Springs Station, and Dr. Levinson sees patients at GBMC, and we're both of us happy to talk to you about HPV-related issues. They're all along the spectrum of severity of disease.
Thank you so much, Dr. Levinson and Trimble. This has been a wonderful conversation, and I'm sure we could chat about this for another hour or two or three. But I'd love to turn things over to our audience now and see what questions they have coming in for us. As always, I encourage those of you watching live to continue to pose questions to the three of us using the chat function below. We will do our best to respond to as many of the questions as we can in the time that we have left. So moving right along, for our first question, what are the current recommendations for women with persistent positive high-risk HPV with normal cytology or low-grade dysplasia, and specific interest in patients that have greater than 5 years of, they get their pap, their colpo, their biopsy, and they're just showing persistent HPV?
You want to do this? You want me to do it?
Go right ahead, Dr. Trimble.
I had so many patients in that situation, and really, as long as there's nothing in your pap smears to suggest the presence of a high-grade lesion, we don't need to do anything. We just follow you, of course, a little bit more closely than we follow people who don't have detectable HPV, but it's a little bit crazy. And the thing to keep in mind, actually, is if you go and do a destructive or incisional procedure, you're not getting rid of the HPV. There is probably residual HPV in cells that look perfectly normal. And so we're working really hard on trying to come up with therapies for HPV infection. It's a big problem.
Do these recommendations change for ladies that are greater than 65? So your older ladies?
Yeah, I can talk about this. This is a strong area of interest of mine as well, because I think that particularly with looking at vaccination rates, and a lot of our younger women now may have been vaccinated, but we still see this, there is a second kind of hump in the incidence of cervical cancer in older women. And so I think that it's really important to know your history. And even though our overall screening guidelines say, oh, well, maybe we don't have to screen women who are over the age of 65, I usually am quite precarious about that, because we know that HPV can be latent, and we know that it can show up. And, commonly we'll have women who come to us who are HPV positive and say, what do you mean I have HPV? I haven't had sex in years. Well, you were exposed to it at some point, and now it's showing its face. And so I do really think that it's important to know your history, talk about it with your doctor, and make sure that you're being screened, particularly if you've had any recent history of HPV.
And another thing to keep in mind, thank you, Dr. Levinson, is that it's not clear, that we actually ever get rid of HPV. It may be that the HPV goes latent, like chickenpox. You have it when you're a kid, get over it, minding your own business, and then 50 years later, some people get shingles. Most people don't. And we know where the chickenpox virus has been hanging out. And it's not clear at all whether HPV goes dormant somewhere and we can't see it. But, as long as it stays dormant, doesn't do anything, I'm good with that.
Great. I think importantly, just discussing these things with your doctor is really important, especially as you hit those age cutoffs, because they're not as hard and fast, especially when you have a history. Moving right along with our questions, what is your advice for women over 35 to prevent HPV infection and cervical cancer? And how do our preventative medical choices change across the lifespan of women?
Dr. Levinson, take it away.
Okay. Yeah. So, I mean, as Dr. Trimble was talking about with the HPV vaccine, the HPV vaccine really is an excellent tool across ages. And part of the thing to acknowledge with the HPV vaccine is even if you've been exposed, for example, to type 18, let's say, the HPV vaccine doesn't only cover type 18. So if you haven't been exposed to the other 8 types, you are still getting full prevention of those other types. And you're getting that boost in the immunity, like Dr. Trimble talked about, to really help your body fight the infection to the best of its ability. And so really, this is an excellent tool for us to use across the lifespan and in many ways with, preventing recurrent high-grade dysplasias as well. And so that I think is the best tool in terms of prevention. Of course, in addition, secondary prevention is critical. So doing screening and making sure that we're staying up to date with screening and making sure that you understand what your doctor is recommending based on your own personal history.
Great. The next question we have from our viewers is, does HPV cause cancer only in the cervix, or are there connections to other gynecologic cancers as well?
Most commonly, HPV causes cancers in the cervix, but it can also cause cancers of the vagina, the vulva, the perianal area, and back of your throat. Now, surprisingly to me, not intuitively, most people who get HPV cancers of the back of the head and neck are heterosexual men. And we don't, as of yet, have a way to screen for it there. And so prevention becomes important for males as well. And you may want to talk about that with your partner.
Yeah, so one of the things that I talk about not infrequently with patients is the cervical cells, and particularly the cells in what we call the squamocolumnar junction, which is kind of that transition between the inside and the outside of the cervix. Those are the cells where HPV likes to live the most. So we know both men and women have HPV, but for example, penile cancers are not as common, right? And that's because the skin of the penis is not affected in the same way as those cells in the cervix. And so different tissues have different affinity for the HPV. And so it can cause vulvar cancers, as Dr. Trimble said, vaginal cancers, but those tend to be a little bit less common than cervical cancers solely because of the types of cells and where HPV likes to live.
We don't have a test for HPV in the penis.
Exactly.
Yeah, I think we mentioned here how these cancers can affect different tissues and also men. One of the questions we got from one of our viewers, is there a role for men in primary infection prevention, and should men be getting the HPV vaccine?
Yeah, your partner, you should. So whether that partner is the same gender as you or not, you both need to be, or as many of them as you think, need to be vaccinated to prevent HPV infections or to keep them subdued.
Yeah, and for the oropharyngeal cancers as well, for themselves, because those are becoming more and more common in men. So really becoming more and more important.
Yeah. Expanding on populations that could benefit from the HPV vaccine. One viewer asked, should a woman that's over 50 years of age with a history of HPV infection still receive the vaccine? Is there any benefit there for her?
Well, technically, the insurances will stop paying for it at age 45. However, we all know that HPV doesn't stop there. And so people who have persistent HPV infections are at higher risk for developing cervical cancer. So that's one issue you can take to your insurance company. People whose immune systems are suppressed, like people who have organ transplants and living with HIV or have autoimmune disorders for which they're taking immune suppressive medication should definitely get the vaccine. And, when I work with my colleagues who do organ transplants, we try to get them to vaccinate their patients before they get transplanted, after which they're going to be taking medications to suppress their immune response to the transplanted organ.
Yeah, and I should add that one of the, we are actually running a cohort in our therapeutic vaccine trial for patients who are awaiting transplant to see if we can get rid of the virus before transplantation is performed.
Yeah, and we have a compassionate use protocol as well.
Yeah.
With the artesunate.
It's such an important population to try to prevent, progression of this disease.
Thanks. Another question that we have is there any concern that HPV types might change and be less affected by the vaccine? Kind of like the flu vaccine, like it mutates and that kind of thing.
The HPV doesn't have very much what we call selection pressure. There's not a very big immune response to it, so it has no reason to mutate. And the two proteins that Dr. Levinson talked about, E6 and E7, both of those are required, but not sufficient, to initiate the development of precancerous lesions and maintain it in cancers. So, because it already has two of its own proteins that are driving the whole situation, that's a reason that it doesn't need as much to mutate. It may be mutated later stage disease, and so that requires a different approach for therapies, especially immunotherapies.
Agreed.
Thanks, Dr. Trimble.
Mm-hmm.
What exactly is an HPV test? Is it a blood test? And if you no longer have a cervix, do we still need to be worried about this?
Yeah, so this is a great question, and I'm so glad you asked. And so, an HPV test, this is why people become so confused when they say, I got a pap smear. Because when we do a pap smear, that brushing of the cervix, that is actually how we can do an HPV test as well. So on that same sample that we take the cells to do a pap smear, that is how we do the HPV test as well. So there's not a second procedure that's needed. It is not a blood test that's needed. We simply do it once we're doing the speculum exam, taking that swab of the cervix, we can run both the pap smear and the HPV test on that test. And if you no longer have a cervix, the most important thing is to know your history. So if you have had a prior history of a high-grade lesion or a high-grade pre-cancer, then you need to continue to get pap smears of the vagina, because we know that HPV virus has proven that it can affect those tissues. And as we just discussed, can also affect the vagina and can also affect other areas such as the vulva.
Great. I think we can wrap up with one last question. How often should patients have a pap smear and HPV tests after a normal test, and in what age should they stop?
Dr. Levinson, you want to do that?
Yeah, so for patients who have never had abnormal screening, the most important thing is to know which kind of test you had, because the HPV test is, as we said, has a very high sensitivity. And so we are able to determine who has HPV. And if you do not have HPV, most importantly, we know that your risk over the next 5 years is extremely low. And that's why it's every 5 years if you have a negative HPV test.
Okay. Well, thank you all for your attention this evening. As I said, you know how to reach us. We're happy to see you if you want a second opinion or a consultation or an exam. Here we are right close by. So thanks for your attention, and
thanks everybody so much.
Questions.
Thanks everyone. Have a great night.